Whereas at the other point, there's nobody else sees. So just kind of try to follow along.
All right. So this is a pretty short case. We'll get started. It's a 65-year-old female patient presents with a mild vision loss, photophobia, pain in the left eye for 1 week. The patient has a history of MAC-on retinal detachment repaired by Dr. Cohen in September of 2011 with vitrectomy, laser, and gas. She had subsequent cataract surgery about 6 months later, and she had one episode of anterior uveitis in the left eye in 2013, managed with drops. Medical history includes hypercholesterolemia and ovarian cancer, surgical history, hysterectomy. She's on Wellbutrin. Her vision was 20/25 in the right eye, and with the eye in question is 20/63, but she pinholed down to 20/32. IOP in the right eye 18, left was 19. Anterior segment showed a Krukenberg spindle in the right eye with a 3+ NS, and left eye also Krukenberg spindle, 1+ cell, and traced flare. And the iris is as follows.
Okay, so we have a slim photo of the iris. My attention is drawn to the pupillary margin. It looks like there is like a posterior synechia and kind of almost 360. It looks like maybe like 300 degrees.
What makes you say that?
All of the kind of irregular ridges around the pupillary margin.
I don't think that has to be synechia. I think it can just be sort of the edge of the iris with a little gap on the bottom. I don't think she actually had synechia.
Okay.
This picture doesn't show much. Why don't you do the next one? This is hard to photograph. There you go. That's kind of the finding.
Ooh, okay, so this is the like retroillumination, and you can see some atrophy superiorly.
Okay, good.
Okay, so here is a UBM photo. It does look like the behind, or I guess posterior to the iris, there is a hyperreflective material.
Good. I guess you're a first year. What do you think that might be behind the iris?
So I would imagine like the ciliary body and then the trabecular meshwork holding the capsule and the IOL.
Okay, so yeah, that's the IOL, right?
Mm-hmm.
So I'm pointing, but they can't see that. Sam, you got to point to it. So yeah, that's the IOL. And then the ciliary body is just over on the side. So the ciliary body, Sam, can you tell where the ciliary body is? Yeah, way over there. So that's your ciliary body, is your ciliary body. And then that's just a bunch of crap. You know, when people do cataract surgery, sometimes they just don't get everything. It drives me a little crazy because we have to go do IOL. So that's probably just old lens material there. But then anything about the IOL that's sort of, this is the, now I don't see the orientations on here somewhere, but on the right is 12 o'clock and on the left is 6 o'clock. So this is a vertical UVM. Okay,
so it looks like there's like superior displacement of the IOL.
Yeah, exactly. So a subluxated lens. And I think that's all the pictures. Do you have a differential in mind?
So if they had pigment on the cornea, like the case spindle, this could be pigmentary. I guess case spindle normally in pigment dispersion, but I guess if there's like pseudo exfoliation, it can also be on that. Maybe it's like dislocation from unstable trabecular, or excuse me, unstable. I'm losing my thought. Unstable zonules.
Yeah, exactly. And there's a term for it when you have cell, a subluxated lens, some transillumination defects. Two of the other elements that were not in it, unless you saw microhyphema on gonio, but I didn't see one on the pictures.
She never quite had the hyphema. So do you know what he's getting at, Ken? It's just syndrome.
Is this like a is it phacogenic?
You, yeah, yeah, it's
Oh, there we
UGH.
go.
Yeah, so UVH, or also known as Ellingson syndrome. That's right. Differential also includes trauma to the eye that could have perhaps caused their symptoms, anterior uveitis or rebound iritis following cataract surgery, although this was quite a ways away from cataract surgery, and chronic postoperative endophthalmitis, which could happen a year later. So this is a very mild UGH syndrome. She quieted down only after just topical Pred Forte, and she was rapidly tapered without recurrence. So UGH, also known as Ellingson syndrome, is a complication of intraocular lens implantation where chafing from the implant leads to a spectrum of iris transillumination defects and a hyphema with raised IOP and pigment dispersion. The etiology. You're more likely to get this if you have an ACIOL, followed by sulcus-mounted IOL, followed by a capsular bag IOL. So as you go more posteriorly, you're less likely to get this. And there are implicated IOLs. Some IOLs are more likely to do this than others, especially depending on their location. So an iris-supported IOL is most likely, since it's literally attached to the iris. A scleral-fixated IOL, followed by a single piece, more than 3-piece lens in the sulcus. So make sure you never put a single piece in the sulcus, and it's primarily due to this reason you're way more likely to get UGH. Capsular bag, single piece in the setting of a pseudoexfoliation or plateau iris. Single pieces, I think, in the bag tend to rest more anteriorly within the bag, so it does have more likelihood to cause UGH if you have some of these conditions. Lastly, you could also get a late onset UGH in the setting of if you have a sulcus IOL, and then you develop a Sommering ring, which is after when you do a capsulorhexis, there's sometimes you can get this development of these epithelial cells tend to clump up. They form this little white material like a scar, and that can push your sulcus mounted lens anteriorly, increasing your chance of getting a late onset UGH. Pathophysiology and prevention. So repetitive mechanical iris or ciliary trauma by malposition or subluxated lens. Exact pathology is unknown. It's likely an activation of innate immunity, complement activation, maybe avirulent bacteria adherence to the IOL. It's iris chafing. And so how do you prevent this? Well, there are a couple parameters you can use whenever you do have to place in an ACIOL. You should always measure the white to white horizontally. I think averagely it's about 11.8 millimeters. And larger tends to damage the angles, decompensates the corneal endothelium. Smaller lenses can rotate or tilt. Because your largest is horizontally, you always want to place your ACIOLs horizontally. So the IOL recommendations are 1 piece in the bag, 3 pieces in the sulcus with optic capture, and vaulting the ACIOL to prevent upside down syndrome. So what is optic capture and upside down syndrome? I'll show you a picture. So in the top, you have the surgeon placed it in the sulcus, and now they're slowly just putting the lens into the bag, but the haptics remain in the sulcus. So that's called optic capture. It helps reduce the risk of developing this problem or complication. And upside down syndrome is when your IOL is facing posteriorly when it's in the AC. So you can imagine that could also cause more chafing.
If I could just chime in, I've seen some upside down syndrome, in my experience, occurs with the best cataract surgeons because they're never putting in ACIOLs. So what happens is they get that one case in 5 years where they put an ACIOL in and they stick it in upside down just because they're all freaked out and they haven't put an ACIOL. So just be careful about upside down. I've seen some really, really good surgeons do that, and it's a pain fixing it.
So some of the symptoms include blurred vision, photophobia, redness, ocular pain. Signs would include increased intraocular pressure, hyphema, AC cells, flare, hypopyon, rubeosis, transillumination. You could also get a vitreous hemorrhage, which would be called UGH plus syndrome if there's a posterior capsule is rupture, malposition IOL, and or CME. And so to diagnose, usually you'd use a gonio just to see if you have a microhyphema. And you would also use it to see for increased pigments of TM. Diagnosis, the best one is UVM. And most doctors are also getting OCT MAC just to make sure there's no CME. And so treatment, IOL repositioning or exchange is undertaken if not controlled by medical therapy. So first you try out medical therapy, and so you tackle what you're dealing with. So the U is uveitis, you use some topical steroids. The glaucoma, you use prostaglandin analogs, beta blockers, alpha agonists, CAIs, but you should avoid pylo because you could increase chafing. For the hyphema, you just limit activity, cycloplegics, topical steroids for both the hyphema and uveitis. If there's plateau iris is causing the cause, and this could happen even if the lens is in the bag, you typically only need an LPI. If you can see which blood vessel is causing your hyphema, you could YAG the vessel as well. And that's all.
It's very nice. So go back to the UBM.
Oh.
What do you think this patient was? People said sublux, but I thought it was
malposition.
yeah, it was malposition.
It half the lens.
And the other thing I can tell you, some of the best surgeons, especially the best young surgeons, you guys do small pupil cases. And that's where I've seen people malposition lenses, because you just can't, you can't see it. And then afterwards, you're like,
use your hooks. It takes more time.
yeah.
You know, because you're not into using hooks. But try to see the bag. This lens is not in the bag on the right.